The reason why I went to bariatrics, it's very, very special. I was gynecologist in Poland, obstetrician, which as I told you, I love to deliver babies and have this feeling of a new life. I wanted to always be a surgeon. However, in Poland at that time, women are not very often seen as a surgeon. Become a women surgeon was extremely rare and almost impossible. When I came to United States, I got this opportunity to work with Dr. Phoebe, to see what bariatric surgery is. At that time, there was no bariatric surgery as a part of medicine available in Poland. We did not know surgery for morbid obesity. Morbid obesity wasn't a problem at that time in Europe or in Poland. When I came over here and saw what bariatric surgery, especially bariatric medicine, does for this morbidly obese patient. And I saw the patient as a whole. You have to work with bariatric patient not only as a one problem patient, it's a complex patient. You have to work with patient at the time of surgery, and you will work with this patient after surgery for a long time. It's your patient. It's very similar to your obstetrics patient. When you follow the patients through the 9 months of pregnancy, when you at the very beginning and at the very end of this beautiful process, and you see this new life coming. It's the same with bariatric patients. You go through the process of preparing them for surgery, doing a surgery, and a long time after surgery, and you see all the changes, all these differences in a patient's life, and you're just a part of it. This is the most joyful feeling what you can have. Most likely the availability of food and treating the dining as a social event. We're no longer in the process of eating to survive. We are in the process of eating as a continuation of our daily routine, daily pleasure. We're going out and we eat. We're going for the meetings and we eat. We, unfortunately, consume much more than what we're supposed to. That probably is one of the reasons, but the reasons are very, very complex. We also have a different portion sizes. If you go to Europe, unfortunately, what we have on one plate in the United States, it will feed about 4 people in Europe. The difference is big. And big is not always better. The thing what I noticed, which is very similar between morbidly obese women and pregnant women, but they are similar on various levels in emotional stage, in the way how they approach outside world. The pregnant woman and morbidly obese woman, both of them know that they are seen by the world as something special. Unfortunately, for morbidly obese women, that does not end in 9 months. For pregnant women, they know that after 9 months they will deliver a baby and have the joy. In morbid obese women, they know that after a single month, they usually not getting better, getting worse. They still perceived by the society as something different, and nobody likes to be different. We want to be same. We want to belong to the society. We don't want to be on the side of it. Pregnant women also perceive everything in a very emotional way, the same morbidly obese women. They know that they are on the tip of the tongues of many people because they are morbidly obese. They know that when they go to work, when somebody is coming, the first person who they notice is this morbidly obese woman or pregnant woman. Everybody else is sort of in a shade. And that puts them into the situation that no matter what you do, no matter how you react, the perception is different. They have much more emotional problems, much more everyday problems than a regular person. No matter what they eat, they are perceived like overeaters. No matter where they go, they perceive like they're doing something wrong. And that sticks with a woman. That sticks and tell her that I'm not as good as everybody else because I'm on the area where everybody can see me. And every single second, every single minute, they know that they are observed. And that causes a lot of emotional distress. So we did research in regards of comorbidities and resolution of different comorbidities after different types of bariatric surgery. There are many types of bariatric surgery which you can do, and all of them, especially gastric bypass, biliopancreatic diversion, or lap band, have a different mechanism of how they works and how we lose weight and how much of weight we will lose, and also has a different impact on resolution of comorbidities. We did this study, and similar study we done by different centers. We found that the best resolution of diabetes we can achieve after biliopancreatic diversion and gastric bypass. We found that diabetes, hypertension, and especially sleep apnea will resolve in almost 90% of our patients. I also did research with Dr. Phoebe in different aspects of resolution of the weight and comorbidities, as well as outcome after gastric bypasses. And we compared the gastric bypass, which is banded and non-banded, and weight resolution in long term. That's very fascinating, it's still ongoing. There is many other research going on right now in the world, trying to figure it out why, trying to explain why diabetes resolve after gastric bypass. It's very fascinating. We know a little, but we're trying to get more information. We know that gastric tract right now, it's not just an organ which is purely for the absorption of the food. It's also very active hormonal organ, makes more than 20 different hormones. We know that fat tissue is very active hormonal organ, and that being obese, it takes a very big role on your response, in the inflammatory response, hormonal response. It just affects your entire body, not only one system. In bariatric surgery, we have three major groups of the procedures. They are restrictive procedures, like lap adjustable gastric band. They are procedures which are more malabsorptive, like biliopancreatic diversion, and procedures which are mixed, restrictive and malabsorptive, like gastric bypass. Biliopancreatic diversion is a procedure which is more adequate for severely malignant obese patient, and that procedure gives more malabsorption. The absorption of a nutrient is less than we have with a gastric bypass. That causes, unfortunately, more symptoms of protein malnutrition, calcium malnutrition, and unfortunately more diarrhea than gastric bypass. Gastric bypass is sort of like a gold middle in between the restrictive procedure and malabsorptive procedures, causing some malabsorption and some restriction by creating a small pouch about 15 to 20 cc in volume and connecting this pouch to the small bowel. We bypass very short segment of the small bowel and the gastric and the stomach. That causes less malabsorption, more absorption of the good nutrient, and less complication like protein malnutrition or diarrhea. There is one excellent procedure for everybody who is morbidly obese. We have to look at the patient, at his comorbidities, if he has a diabetes or no, if he has a hypertension or no, if he has any problems, which we know that one procedure will be better than other. Restrictive procedures, they are good for a patient who don't have comorbidities, who have a little bit of obesity. However, we know that gastric bypass or malabsorptive procedures are better for extremely obese patients. We have to talk to the patient because every one of this procedure is a good procedure. It's just we have to find the best procedure for a specific person. That's why we spend lots of time trying to know the patient, trying to know the habits, how he eats, what the desire is, what is the patient desire to lose weight, how much and how quickly. We know that restrictive procedures will allow you to lose weight slowly. Gastric bypass will allow you to lose weight more rapidly. We know that if you want to exercise and you have a will of power to change your nutrition, to change the way how you eat, the restrictive procedure will be fine. However, if you want the feedback from your own body, the gastric bypass will be better for you. So there is no one answer which procedure is the best. They are different procedures, and every one has some unique quality which we have to match with the patient and the patient with procedure. We have an entire team of doctor, specialist, nutritionist, psych therapist, which work with the patient, trying to find out which procedure is the best and which procedure will give the patient the most benefits.